Joining us tonight. Thanks everybody who's joining us tonight. My name is Courtney Williams. I am with WAS. Our topic tonight is clean air and children's health. We're joined by pediatric pulmonologist, Dr. Amy Brown. We're just waiting to get to critical mass. And once we've got folks on the call, we'll get started. In the meantime, please use the chat to introduce yourself, your name, your organization, and your location. And what is your favorite season is our icebreaker for tonight. And we actually have, this is our first hybrid WAS task force, zero waste task force meeting. So we have, I'm joining you from Bowman Towers in Peekskill, and Tina Bongar and Joanne Boniello are joining from Dunbar Heights with residents there. So forgive us if there's any technical snafus. This is our first time trying that. So thank you all for getting on. All right, Caitlin, does it look like the waiting room slowed down?
I think so.
Okay, great. All right, so with that, I will get started. As I said, my name is Courtney Williams. I am a member of WAS. What is WAS? It stands for Westchester Alliance for Sustainable Solutions. It's an alliance of community organizations from across Westchester County working to close the Wheelabrator trash incinerator in Peekskill and move Westchester County towards zero waste. So our plan for tonight, we're doing the welcome now. I'll give a small bit of background, and then I will welcome our guest speaker for tonight, Dr. Amy Brown, pediatric pulmonologist, who will be talking to us specifically about air pollution and the impacts on children's health. And then we will open it up to Q&A. Folks can feel free to use the chat for asking any questions, or we will invite people to come off mute and ask their questions at the end. So why is WAS holding this month's Zero Waste Task Force meeting about air pollution in children's health? Well, Peekskill is home to two major air polluters. One of those is the BASF chemical plant. The other is the Wheelabrator trash incinerator. So Wheelabrator is the largest industrial air polluter in Westchester County. And on this slide is just a few of the pollutants that it generates, how much it generates, and what the health effects of those are. And so the number one is greenhouse gas emissions. That's what's causing climate change. But the impacts on public health and human health are caused by things like nitrogen oxides, sulfur dioxide. Those things trigger asthma attacks. Particulate matter contributes to heart attacks and strokes, also aggravates asthma. So these are all pollutants that have clear effects on public health. And really, no one is more vulnerable to these than our kids. And that is why we invited Dr. Brown here to speak with us tonight. This graph comes from the New York State Department of Health. And what it shows is the rate of asthma.
Courtney, I'm sorry to interrupt. Are people seeing the slideshow?
Oh, did I not share?
I don't think, yeah.
Oh, sorry.
I shared, but I only see the wall screen. If it was full screen, I think we could see it a little bit better. Yeah.
All right. What are we doing now?
Yes.
Are folks seeing the screen? Yes. Caitlin, can you tell me?
I'm seeing
Yes.
not the full screen. I'm seeing like part of your computer screen.
Okay.
And then I do see the slideshow, but not in slide view.
Okay.
Yeah.
That's looking good now.
Oh, there's
Yep.
much
Okay.
better.
Excellent. Thanks, Courtney.
Thank you for pointing that out. So this graph shows the rates of asthma for us here in Peekskill. So the red bar is how many cases of asthma in our population, and it's at 100. If you look at the rest of Westchester County, it's 57. So we're almost double the rate of asthma here in Peekskill than the rest of Westchester County. If we look at the state as a whole, we are, so New York State did this thing to try and measure the impacts of pollution on what they called disadvantaged communities. And what they found is that my census tract here in Peekskill has a higher environmental burden than 98% of census tracts in New York State. So that when you look at what is that burden, you can see that municipal waste combustors, that's the trash incinerator, ranks really highly. But to pair with that, and what makes us a disadvantaged community according to New York State, is that we are a vulnerable population, meaning not only do we have high levels of asthma, COPD, that's chronic obstructive pulmonary disease, heart attack hospitalizations, but we also have folks that maybe can't afford to close all the windows and run the air conditioner when it's hot and the incinerator is polluting, or they can't, they are overburdened by the cost of their rent, things like that. So we're really feeling the health effects of the air pollution that is here. So with that, I have set the stage of why we invited Dr. Brown to join us here tonight. So I'd just like to read her bio to give you an idea of who she is and why we invited her and are so grateful she was able to join. So Dr. Amy Brown is board certified in pediatric pulmonology and general pediatrics. So pediatrics meaning kids, pulmonology meaning lungs and your respiratory system. She pursued her undergraduate degree at Emory University, her med school degree at Temple University, and also got a master's degree in bioethics at the University of Pennsylvania. She's an assistant professor of pediatrics at New York Medical College School of Medicine right here in Westchester County. And she is currently employed by Boston Children's Health Physicians and is an attending physician in pediatric pulmonology at Maria Fareri Children's Hospital here in Westchester County. In addition to seeing patients, she's engaged in education, research, public health, and advocacy. And really important for why we have her here tonight is that she is a lead physician for the Children's Environmental Health Center of the Hudson Valley, a center of excellence awarded by New York State. And she is a partner it's a partner center to the New York State Department of Health funded New York State Children's Environmental Health Centers. She's given numerous lectures locally and nationally on pediatric asthma, environmentally triggered respiratory diseases, air pollution in schools, tobacco and vaping, and preventative pediatric pulmonology. So she's very accomplished, very respected in her field, and knows a ton. And we are so grateful that she was willing to join us for our November Zero Waste Task Force meeting so that we could hear directly from her. And maybe more importantly, she could hear from us and hear our questions and answer those for us. So with that, I would like to turn it over to Dr. Amy Brown with my thanks. Thank you, Dr. Brown.
Great, thank you so much. Thank you for that introduction, and thank you to the entire task force for having me. I am hopeful for no interruptions, but I will mention amongst the many hats, one of them is being a mom, and so my children have been instructed to stay out, but if there are any interruptions, I will do the best I can. I am going to share my screen, so just give me a moment to bring this up. Can everyone see my slides? Is that okay? Okay, great.
Yep.
And so, thank you so much, Dr. Williams, for that introduction. This is such a critical topic to talk about. I am so glad that we are here tonight to do that. And I'm going to throw together a bunch of big picture concepts as we think about air pollution. I'm also going to talk, interestingly, about air pollution in schools, which is a lot of the work that I do. Because as a pediatric pulmonologist, thinking about where children learn and breathe and where they're exposed as an occupational hazard, the occupation of being students, really thinking about, of course, the homes in your area, but then also thinking about the schools as well. So again, this is me. And as Dr. Williams mentioned, I wear many hats with our environmental program and here locally. I see patients at Fareri. I teach for New York Medical College, and then I do research, advocacy, and outreach. I also wanted to mention that I'm joined tonight by one of my dear colleagues, Dr. Amy Ansell. She is our Director for Community Engagement. She is a Senior Associate Dean at New York Medical College for student experience. And when you see us in the community, it's really Team Amy. So even though I'm presenting a lot of the pulmonology stuff tonight, as you get to know us, we work as a really strong team.
Thank you, Dr. Brown. It's a pleasure really to work with someone of your caliber who's just so outstanding. Thank you.
Thank you. So, I'm going to keep it probably to hopefully about 20 minutes of just content. Please feel free to interrupt me, but we really want to have time for Q&A and discussion. So I'll give just a little bit more information about our New York State and local programs. But really, we're going to talk and establish a foundation about understanding the connection of the environment. In particular, we're talking about air pollutants in the environment and human disease. We'll talk about children as a vulnerable population, and then understand how, as a pediatric pulmonary clinician and environmental specialist, the role I play in addressing this high-risk exposure in children. So this is just one photo of many that are taken over the years of our New York State network. So starting in 2017, New York State Department of Health awarded a grant for, there's 8 centers of excellence throughout New York State. We all work together. We meet every year at the Edith Macy Conference Center, not too far from Peekskill. And we meet bi-monthly and work together on a variety of small projects, small and large projects, to build capacity in the areas of children's environmental health. I believe some of my colleagues from Mount Sinai may have even connected with this group. Many of them do a lot of work in air pollution, various environmental exposures as well. But we're really proud to be a part of this group. And one of the things for you to know is that not only is this a statewide network, but again, our local center, we're really here for you. You may have interacted with various faculty members. Our president for Boston Children's Health Physicians, not in Boston, we're here locally in New York and Connecticut, Dr. Alan Dozer, who founded the center in 2008 with Dr. Robert Ambler, who's the Dean of New York Medical College School of Health Sciences and Practice, Dr. Krishnan, who's my division chief, and all these wonderful colleagues. We work together in interdisciplinary fashion to build capacity in children's environmental health. And these are the centers throughout the state. So one of the things to think about is the wonderful work that's being done by the WASP task force is likely being done by other organizations throughout the state in varying capacities. And something we did as environmental centers was to come together to share best ideas and practices and build capacity. So as we talk about next steps, networking on behalf of your program would be something that we would be proud and honored to do, because it's really important work to connect those dots across New York State. As I mentioned, the center was founded in 2008. This picture is not from 2008, but it's one of the earlier pictures. Our group has only grown, and it is as you can see, it lives out of our division of pediatric pulmonology, allergy, immunology, and sleep medicine. And interestingly, we're actually the only division in pediatric pulmonology in the country that has this model and an environmental program. We have a really large interdisciplinary faculty, and we work closely with also our division's research program. We manage a database about exposures in environmental health, and then we work closely with our local departments of health. We see a ton of patients just within our pulmonary group. We see over 30,000 children annually, and we screen as many of them as we can, but at least 1/3 of them for environmental exposures. We have offices not only in Westchester County, but throughout the entire Hudson Valley. And so this way we can really make sure that we capture all patients that are in need of specialty care. And another thing that's really great about our model is that we are an insurance-based model, but we see approximately 40% of our patients who are on a state-based insurance, many who live with various social determinants of health and in environmental justice communities. So The last thing to note is that we have a variety of clinical programs. Our clinical programs are integrated in the division. We take care of the sickest patients with asthma. We have a severe asthma registry to better understand environmental exposures and then connect them with remediation efforts. We're going to talk about air pollution as what's called what's called upstream, or meaning factors that determine a disease on a large population level. So we try to address those things in our program, but really a lot of what we do is one patient at a time, and our severe asthma registry helps us to understand that larger, more upstream issues so we can address it at a larger population level. We do a ton of work with tobacco screening and tobacco education. We work closely with our student assistance services programs, and we're really proud to take a lead on that in the county. And then finally, we do consultations. It's called our PEMS program. It's led by Dr. Amler, and we do pediatric environmental medicine consultations if there's a question about an exposure. And so really our model is teamwork. We work together as a team. Trainees, we believe very firmly that an investment in not only the faculty that are doing this work now, but really the next generation, whether it be medical students to high school students, are really the key to addressing these complex issues, such as air pollution that we'll talk about. And then ultimately our goal is to improve environments so we can prevent disease before it happens. The last thing I want to mention is, we did a very zoom in approach where we talked about our local center, our statewide center, but then there are these networks throughout the country through a federally funded program through the CDC and ATSDR, the Agency for Toxic Substances and Disease Registry, which is a great resource if you haven't been there already. These are called the PACEUs, the Pediatric Environmental Health Specialty Units. In New York State is actually the only state-based program, whereas the rest of the country, the model is through this federally funded various regions. And so we have a lot of resources in New York State, not nearly enough, but we do have a lot of resources and we are here to help. So just to, as we get into air pollution, to kind of build the framework, when we think about air pollution and why we're talking about this, it's important that we understand this paradigm of developmental origins of health and disease. And so we want to understand environmental sources of modifiable disease to prevent the onset. And then we want to understand what are these effective public health or clinical interventions that can be done if we can't prevent the disease in the first place. So that's why it's so important that we're talking about air pollution, because it fits into those two buckets. When you hear a talk on environmental exposures, the exposure can happen not necessarily to the individual. It can happen at any point in the even prior, so preconception. Exposures that can happen to parents can be passed along to their children. And we know that air pollution acts in this way. This field is called epigenetics, and it's really a study of how the environment and certain behaviors, so for example, tobacco smoke exposure, behavior to choose to be, can cause epigenetic modifications. Air pollution may not be a behavioral choice, but still that same exposure can affect the way your genes work. And what this means is essentially genetics 101 is that this alters which genes may be made. So it alters which genes are turned on or off. These are just some of the various fancy words of ways that this can happen, but air pollution, we know, can act in this way so that parents who are exposed to high levels of pollutants can then go on in their DNA to pass these along to children. And the individual who's exposed as well, we'll talk about those health outcomes. But important to understand epigenetics. Epigenetic modifications are a normal part of development. It's when toxins in the environment turn on or off genes that aren't meant to be turned on or off. And again, tobacco smoke exposure is one of the more heavily studied inhalation exposures with regards to epigenetics, as well as air pollution. The other thing to think about when we talk about environmental exposures is this exposomic approach. And exposomes, for those who aren't familiar, is a paradigm that encompasses all of our exposures. So air pollution is not the only adverse environmental exposure. And so at any given time, all of those exposures, the co-exposures, can go on to determine human health. And that's why it's so hard to pinpoint a exposure and health outcome, and exposomics, which is a relatively new field over the past several decades, aims to do that. And so one of the challenges is that with exposomics, we really need to be able to have reliable measures of external environmental exposures. That has come online, as Dr. Williams' slide showed, over the past decade to 2 decades, especially more recently with air pollution monitoring. We're able to gather a lot more data. But we don't have decades worth of air pollution data. So we aren't able to correlate what has happened with pollutants over the decades because we didn't have that monitoring. And so the other thing to know is that exposures can also be dynamic over the life course of the environmental genome interaction. So I'm setting the stage for air pollutants, I promise, but I just wanted to kind of explain what we do as environmental pediatricians and why it's so difficult for me to say air pollution causes this and therefore we should do this. The other thing that I want to mention is there's a common adage in pediatrics where children are not just little adults, right? We know that adults are exposed to the environment in a different way than children are. Children have critical windows of development, everything from prenatal development, so fetal life and insults and exposure that can happen in fetal life, on through the different ways that they go on to breathe. Children have different breathing zones. The size of their lungs is different. At any given time, they consume more oxygen per minute, meaning they have a higher effective dose of the environment. Children also breathe faster, so that brings on that same exposure. So the dose to children at any given time of what's in the environment, of what they're breathing in, is higher. Children also have differences in how they metabolize certain things. So just their ability to metabolize many enzyme pathways are less mature. Children also have a less developed blood-brain barrier. So toxins that come in, especially through the lungs that enter into the bloodstream, can also more easily penetrate various tissues, including the brain, and have longer-term effects. Children have just a ton of physiologic and metabolic differences, not only in the way they breathe, but in what they consume, what they ingest, what they put on their skin. And they also have differences in distribution and metabolism of environmental toxins. So as I mentioned, children are not just little adults. These are just some of the key facts about the respiratory symptoms that I mentioned and some of the toxicology concerns. So before I jump into air pollution, the last thing that I just wanted to say is that children can get in a higher effective dose of the environment. And we think about air pollutants, again, it's great that we've had a lot more monitoring of various air pollutants. We can only monitor some. Air pollution, there are a lot of different pollutants. We'll talk about some of the most common offenders. But we really, when we do environmental sampling, need, in order to correlate with health effect and assess for a health risk, understand things like the concentration of pollutants, how long that individual is exposed, external factors, what's around that environment as well. And then everyone will metabolize things different. So there's a variety of host factors. So when I talk about the health risk, it is very difficult to translate. So I just set you up for essentially being able to understand some of the concepts that we're going to talk about with knowing that we can't draw firm conclusions. All we can do is exposure reduction and advocacy, right? So those are the things we have. I don't treat a patient in the hospital for air pollution. I work with community organizations. I work with the Department of Health. I work across the state and lecture nationally to talk about how we can make these changes and promote exposure reduction. So air pollutants are a diverse group of toxins that change the physical, chemical, or biological constituents of the environment. So these are the most common air pollutants, and they come from a variety of different causes. So especially in the Peekskill area, a lot of these may be common, especially because of the incinerator. Carbon monoxide, ground level ozone will fluctuate with certain environmental conditions. We know that those levels go up with higher temperatures as well. lead, sulfur dioxide, particulate matter. In particular, the smallest particulate matter, PM is the abbreviation, but PM 2.5, that can really get down deep into our airways. The smaller the particle size, the more available it is to penetrate deep into our airways. And then nitrogen dioxide, probably one of the biggest offenders. And one of the ways in the public health world that we talk about the aggregate effects of pollution on health are something called DALYs, D-A-L-Y, disability adjusted life years. Because again, it's hard for us to really classify the effects of various pollutants. So this is something that's commonly used when we think about adverse effects. And so we classify air pollutants as those that come from natural sources, area sources, so domestic activities, mobile sources, traffic-related air pollution and vehicle emissions, major stationary sources, and radioactive sources. One of the things, and again, we talk about co-exposures, but that is very high in many areas of Westchester County and you know, in Peekskill as well, is thinking about not just exposure from air pollutants, but exposures that come from naturally occurring sources such as radon. And we know that throughout the Hudson Valley, radon levels are high. So again, but this is considered an air pollutant. So we're not talking about one thing, we're really talking about a variety of exposures and how do we correlate them with health. So I just want to take a little bit of time to talk about the most common offenders. As I mentioned, particulate matter is toxins with very small diameters. PM 2.5 is measured throughout various areas of the Hudson Valley, and it's one of the offenders we worry about the most. And we do know a lot about the health effects. Because they're so small, they can stay around for a while. So they're just extended in the environment for a very long period of time. We know, and I'm sure you remember from the wildfires from 2023, when particulate matter levels were at an all-time high in our region, that PM 2.5 can be associated with a lot of health risks, especially in those that have underlying cardiovascular respiratory disease. It's been associated with premature death in people with heart or lung disease, cardiovascular events, arrhythmias, coronary artery disease, and increased respiratory symptoms, worsening asthma outcomes, and then decreased lung function. And again, particulate matter can occur because of a variety of those causes that I mentioned with air pollution, but can also occur because of other common household things, such as tobacco smoke exposure. So if we think about exposure reduction, addressing just air pollution is only part of what we should address. It's really looking at that exposamic approach and the totality of exposures in our environment. Ozone is atmospheric production from natural sources. We know that ground level ozone comes from a production of environmental interactions, and especially during the warm summer months, it tends to be at an all-time high. It can be a respiratory irritant. It's ground level ozone is actually, when we look at the air quality index, and I'm happy to talk about that, you know, when there's questions, but ground level ozone almost always makes up the largest majority of the air quality index and the flux that we see from day to day, especially over the summer months. We know that it can have direct damage to DNA and immune dysfunction. Carbon monoxide is another big pollutant. Usually it arises from incomplete fossil fuel combustion. We know that at very, very high levels, especially in a non-ventilated area, the exposure can be fatal, and it binds to hemoglobin, therefore allowing your cells, your hemoglobin, to take up less oxygen. And so while it can be acute and cause fatalities, at a chronic low level, it can also cause chronic lower levels of oxygen. Nitrogen dioxide is probably one of the biggest players when we think about air pollution, and that comes up with regards to traffic-related air pollution. Acts as a respiratory irritant. We know that it can have immune effects, especially on the T lymphocyte system, and cause development and progression of chronic lung disease. These are some of the other big players: sulfur dioxide, fossil fuel production, and industrial sources. It is an irritant to both the respiratory system and mucous membranes. Lead used to be a big player. This is really where policy comes into play, because I can't imagine a time when leaded gasoline was around, and lead was volatile in the air. And so because of the policies that were put in place to regulate and eliminate leaded gasoline, children didn't breathe in as much lead. Adults didn't breathe in as much lead. And that was a huge public health advance. So as we think about all of these things, really policy and working with policymakers is a key partner in thinking about prevention of all of these air pollutants. Polycyclic aromatic hydrocarbons are also produced by incomplete combustion of organic materials, and these have been associated and are carcinogens with many forms of lung cancer. VOCs are another air pollutant. They're often formed from indoor air sources as well, and they can cause short-term irritation to mucous membranes, as well as be a long-term carcinogen. And then dioxins also arise from industrial natural processes, and they can accumulate in foods as well. And they can be irritants to the skin, cause developmental and endocrine or immune disruption, and are carcinogenic as well. So this is really scary stuff. And pollution, again, is a combination of all of these things and various where you live, where you spend your day, even where you go, and how close you are to various sources. The dose is going to be different. And then your age is going to also be a factor. So again, it's hard for me to say health effect X is this because of these pollutants when it's such a, hard story to understand. I just have a few more slides on schools just because it's a lot of work I do, and then we can jump to questions. But I do think it's important to think about air pollution impact on schools and communities. I just did a quick Google search to see how close the incinerator is to the school district, and it's about 8 minutes or 2.5 miles. And I don't know if that's ever come up, and if I would be curious, we jump to discussion where conversations about the school and exposure to the school. There is some New York State legislation actually about schools related to highways that was just passed last year. So would just be very interested. When we think about occupational exposures, there's a federal office that regulates that for people who go to work every day in a high-risk environment, but that doesn't exist for schools. And so it's just so important that as community members, we think about how we can advocate, especially for air pollutants near schools. So it's the adjacent outdoor air, and then it's the ventilation and filtration of those buildings. And why is this important? So I just like to kind of break this down. We know that children are about a quarter of the population, 2.3 billion children worldwide. They spend about 20% of their waking hours in school, and many of them who stay for after-school programs and sports probably spend more. And when we think about public health crises, and we talked about some asthma data, Dr. Williams presented that in the beginning, we know that asthma, especially asthma in children and school-age children, that in any given classroom, at least one, if not more, children, likely 2 or more, will have some diagnosis of asthma. And so as we think about the school environment, it mirrors what we just talked about the outdoor environment. And it's really that outdoor adjacent air that can come into schools. And if our school buildings aren't maximized for as efficient as possible ventilation, which we know from the pandemic that they're not ready with the best ventilation. If they don't have adequate filtration systems, then that outdoor adjacent air is actually becoming an indoor occupational exposure to where children learn and breathe. So the challenge of studying the health effects of school-based exposures for children really mirrors some of the population issues that we have. Again, these are multiple pollutants. There's variable timing of exposure. We're talking about a big population when we talk about children in schools. So it's really a challenge to mix these chronic low-level exposures. And I say low-level because the exposure is going to change throughout the day based on where they are. It's also hard to study schools, especially when I give this talk on a national level, because schools in different cities, towns, states, countries look different. And again, regulations for schools kind of fall in the lap of many different offices. Is it the Department of Health? Is it the Department of Education? Is it the Department of Buildings? And it's very, very hard to understand who was responsible for driving this forward at the policy level. So these are just some of the short and long-term symptoms observed of children in schools, especially those that have high levels of air pollutants. We know that it just can be acute coughing, worsening of respiratory symptoms, mucous membrane irritation, headaches, difficulty paying attention and focusing, and then various types of skin irritation can also occur. But then, and this is really where I want to leave you, I have, I think, just a few more slides, but what then happens with with environments that have high levels of air pollution that's able to get into schools? Well, children, especially with asthma, have more exacerbations. It can also lead to severe acute life-threatening events, especially if ventilation is inadequate, such as in carbon monoxide poisoning. But really what ends up happening is it's a vicious cycle where children end up missing school. They don't feel well in school. They don't perform well in school. And it strains the relationship of families in the community and it impacts community trust. So one place out of many to think about when we zoom in and zoom out and think about air pollution is really thinking about our school, because rebuilding all of this is really critical as we think about addressing air pollution in a population. And so these are just some of, there's very, again, limited evidence on school indoor air quality, but these are just some of the studies across the country that do have some good data about indoor air quality. And so some of the studies look at something called elevated total lifetime cancer risk based on a variety of exposures. This is mostly in the European schools. A lot of studies have looked at interventions, like should you have a HEPA filter in a school? Will that help? One would argue, well, we should clean up air pollution in the community rather than having to use a HEPA filter. But they actually found, and this is in a small number of students, and this is based out of Boston, but they did not significantly reduce asthma symptoms and symptom-free days in children. So a HEPA filter, while it sounds like a good intervention, the intervention is really working with policy members, task force, such as what you're doing, to be able to change the outdoor adjacent air. And then finally, this was some of the data that I mentioned, but we know that improving air quality in schools, which again may start with air quality around the school, can improve health outcomes. One of the things we like to say in public health is think globally, act locally, exactly what this task force is doing. These are some of the school-based programs that are happening on a state level. Just wanted to mention, so this is the Schools Impacted by Gross Highways, the SI Act in New York that was just recently passed. This is for new construction of schools. So it is not going to necessarily help where schools are located now, but if a new school is being constructed, there is a distance from a highway that it needs to be, in air pollution and proximity to pollutants, such as, for example, the incinerator, if a new school were to be built, have to be taken into account. And so this was just passed in 2024. It'll be interesting to see where it goes. But it's one of the most progressive in the country to be passed. So this is my last slide, and just thinking about how we impact health individually and collectively. This was that triangle that I was talking about, or I mentioned the upstream, downstream. Where I act and where I was initially trained, where a lot of doctors act, is here. We have an impact, undoubtedly, but we counsel, we educate, we counsel, we educate, and we talk about how we can impact health. But working with task force, such as what you've put together here, working with policymakers, public health professionals, really allows us to work down this triangle. And again, it's in another public health paradigm of upstream and downstream. But really what I do, what Dr. Ansel does, is really trying to think about how can we work through all of these factors so that we can grow a healthy population. And so with that being said, I'm sorry for my dog barking at the last minute, but thank you so much. I have some references here that I'm happy to share. I'm happy to share my slides, and I'll stop the share. Thank you.
Thank you so much. Thank you so much, Dr. Brown. So I'm gonna look in the chat, and certainly if anybody has questions, I think Tina, you mentioned that there was a question from one of the young people there today. If you wanted to start with that one.
Yeah, exactly. Yeah, we had some kids in here while we were setting up and everything. And then they did just come through. But one of them, I said, do you have childhood asthma? And I just sort of did an informal poll with another tenant organizer here. She had terrible asthma, and she's had it as a child going into being an adult. And so, she has 10 grandchildren, and 9 of the grandchildren have asthma. So anyway, it said, are there different levels of asthma for kids? Like, what are the different levels? Which is a good question.
It's a great question.
He came up with that because I said, we're going to ask you questions.
Good question. And another talk I give is called asthmas, plural, because asthma, exactly, it is not one thing. There are so many factors that contribute to asthma. Asthma can happen for a variety of reasons. Some individuals develop asthma because of, again, a family history. It could be a family history for a variety of reasons. Some of it, could be exposure driven. Some children develop asthma because they're born early, so their airways just might be a little bit smaller and they're more prone to infection and having a harder time breathing because of the size of their airways. Some children have bad allergies and that triggers their asthma. And so there are a variety of different types of asthma. And then if you have asthma, the severity, so what type of asthma do you have, can be different. You can have what's called mild intermittent asthma, meaning your symptoms come and go, maybe a cold triggers them, and then you don't have symptoms for a year. Or you can have something called severe persistent asthma, where you have symptoms all the time. And then there's degrees in between. And then finally, to complicate things, you can also, your control can wax and wane, right? You could have the most mild intermittent form of asthma, but you move homes and now you live somewhere where there are high levels of air pollution. And your asthma goes from being mild intermittent to something you didn't think about to now something that's triggered every single day. So asthma is very complex and there are many different types. It's a wonderful question. There are many different triggers. And, there's so much that we already know about asthma, but that we're continuing to learn. So great question.
Okay. And well, she had to go, but she has a question because she has a teen who has asthma. But he had pretty bad asthma. He had an inhaler when he was a kid, and now he's, 16. Yeah, incredible, isn't it? 16. And so it's just seasonal. So is that something that's typical? Because I had childhood asthma and that's my story, but is that pretty much a typical story of kids who have asthma that?
Yeah, so that's a great question. So, we always say that you never really outgrow your asthma. You may always be predisposed to it. But what happens is asthma is related to the diameter of your airways. And when you're small, your airways are small. And when you're small, young children get sick often. So asthma can be more severe in early childhood because of those two factors. So as your airways grow, as you get sick less often, assuming you're on proper medications and well controlled, you can largely outgrow your asthma. Even though you may never truly outgrow it, you can largely come to a place where you really don't have to think about it and don't need any medications at all, potentially. So yes, that is a very common story. It can also be seasonally triggered. So it can be triggered for allergens in the environment that come up in the springtime or the fall. It can be triggered, sometimes it's that bad cold in the winter. So it can come and go. And that's why it's really important to establish care with, especially if you have a history of asthma, with a pulmonary doctor who may just see you once a year, but really to have that baseline so you can do pulmonary function tests, understand your asthma so that you can act in a way that is more preventative and proactive rather than reactive, because we know that's when a lot of people get in trouble with asthma when you're playing catch up.
Jean, do you want to ask her? I wanted to ask her about autoimmune.
Yeah, my grandson, Jamari, he has asthma,
Yeah,
but, it was bad in the beginning. But now with medication, he has a pill, he takes a pill, and he take 2, nebulizer treatment. And also he had the albuterol too.
mhm,
So within the last, let's say 6 months, he gotten better, cause he was sick all year round.
mhm,
You know, the first grade, he was sick the whole year.
mhm.
And
Wow.
in preschool, he was sick the whole year.
Mm-hmm.
This year, during the summer, he started getting better. So maybe the medication he's taking
Okay,
is helping.
great. That's good, because I know he has a nebulizer
Mhm,
and everything.
mhm.
Anyway, I'm curious about your experience with COVID and asthma, whether or not that's been a trigger for autoimmune diseases, or have you treated anybody with kids who?
We have not treated COVID. Well, we've treated tons of kids with COVID. From a pulmonary perspective in pediatrics,
Yeah,
COVID tends to be less of a lung offender than, for example, RSV, the flu, various types of called rhinovirus. There's something called human metapneumovirus. So, COVID can be a threat to health, but as far as lung health goes, like the offenders that trigger asthma, COVID has played less of a role there, but does play a role. And interestingly, and I haven't treated this, but there is some data, especially about new onset type 1 diabetes, which has an autoimmune component, and recent COVID infection. And so I don't completely know the literature, but I know that there are definitely some correlation studies where they're trying to see if there is an association with COVID and various autoimmune disorders. But there's nothing with regards to COVID and asthma onset. And then again, just as far as COVID can do a lot of things, but we don't see it triggering asthma exacerbations the way we see other viruses that we've known about. Um, so, um, so yes, but just very important that we prevent all viruses we can think of in children, especially in those with asthma.
yeah, and in long-term COVID too, which I'm just learning about too. But anyway, I was just wondering about the connection with that, the pulmonary, anyway.
Mhm.
And I just wanted to add, we're here at Dunbar, but there's also a sewage treatment plant that's over here. In
Mhm.
addition to the incinerator.
Yeah, we definitely, I feel like Peekskill has a bullseye on its back because we have the sewage treatment plant, we have the trash incinerator, we have the chemical plant. On our border, we have the gypsum plant, we have the nuclear plant, we have the fracked gas pipeline, we have Route 9, and one of the main thoroughfares, the town of Cortland got New York State Department of Transportation to say that heavy trucks can't be on that road, the Bear Mountain extension, during the day, which then reroutes all of the truck traffic through Peekskill, through downtown Peekskill, past our schools and past like where I am right now at Bowman Towers. So we definitely have that exposome kind of situation with all of these different sources.
Mhm.
I had a question, kind of like a more nitty-gritty question, as a parent. Like, what are the things that parents can do to try and protect their kids from getting asthma in the first place? Or if your child already is using an inhaler or has an asthma diagnosis, like what are the things parents can do to, prevent either them getting it or having a flare or having an asthma attack? What do you recommend for families?
So that's a great question. I mean, as far as preventing asthma, One of the main things is those modifiable exposures. So smoking, that's why we do a lot of our tobacco work. Smoke in the home, or even something called third hand smoke, where a parent or caregiver may smoke, but they smoke out of the house, but they come home and it's on their clothes, it's in their hair. We know that third hand smoke exposure can adversely affect lung function in children. We're actually looking at, right now we're doing a study looking at radon and lung function, and radon measurements in homes. The work that you're doing with air pollution and just trying to promote as healthy environment as possible. We know it's not so easy to just breathe in clean air, but it should be. So some of those things, our individual behaviors can change, and we know that that can reduce your risk for asthma. Some of it is also just genetic priming, right? You're prone to asthma, you have a family history, allergies, things like that. And so thinking about on those days where you can follow the air quality index, it's interesting. Probably many of you on the call right now have the app, I'm sure, from airnow.gov. It wasn't really meant to be a public health tool for everyone right away. It kind of was like cats out of the bag when the wildfires were happening in our region and everyone downloaded it. But it is a good tool because it can tell you, to your question, if you already have asthma, what can you do to prevent exacerbations or prevent it from being worse? So one of the things is to just know your triggers. And then when there is a trigger, especially those that are more ubiquitous, such as a air pollution, a day with high levels of air pollution, avoiding that, changing your behavior, avoiding tobacco, getting your home checked for radon, even though that isn't a specific asthma trigger as far as we know yet. It is a carcinogen that can lead to lung cancer later in life. So it's really about those modifiable risk factors. And then the last thing, and again, this is biased, but if your child does have asthma, speaking to your pediatrician about it, maybe seeing an asthma specialist. We don't want to ever overwhelm parents. We know parents already have so much to do. So we don't want to add another doctor in the mix, but sometimes it's, what I like about being a specialist is I can be very focused on one thing. I still think about the big picture, but I can spend my visit talking about asthma and really focused on asthma. And I think that's a really hard thing for general pediatricians. They have so many things to cover in a well visit. So if it is a concern, that's what we're here for. And that's why we have our model of having offices throughout the county. So really trying to have that proactive asthma approach, as opposed to reactive approach where it's exacerbations and acute care visits.
Thanks. And could you or Dr. Ansel put in the chat, if you said you had multiple offices, if
Yep.
families want to try and get an appointment, or they have concerns and want to see one of the people in the program, could we drop a link in the chat for that? And we can also provide it. We have also been in touch with our local providers like Open Door and Sun River that are here in Peekskill and Ossining areas. So they weren't able to send representatives to be on tonight or be at our locations tonight, but we've been in touch with them. So if anybody watching wants to be connected with them or with Dr. Brown or Dr. Ansel and their programs, feel free to reach out to WAS. It's WAS, WASS Peekskill @gmail.com. And we will be happy to get you that contact information so that you can reach out to them. So Ellen, and then I think we're very close to time, and we'll have a couple of thank yous and action items for people. Go ahead, Ellen.
Thank you. Thank you so much. This was such an outstanding presentation, Dr. Brown, and just really glad to not only learn and enable others to learn more about air pollution, but also about the facility, the Children's Environmental Health Center, which is so important. And to that, and I'm just wondering how involved the Children's Environmental Health Center and your work is in advocating for policies. How do you help, or can you help decision makers and inform the policies that they could consider, so that some of these things are out of the control of the individual family. And it is so hard because I think parents and families try so hard to protect their children. And then we have the limits of, the situation where there are these exposures, from other sources that families and parents have no control over. And you talked about the SIAC, and I know that's one example, but can you talk a little bit about the advocacy that the center can do and the kinds of work that you may get involved with in that regard?
Yes, absolutely. So that's a great question. So we work as hyper local as it gets. So Dr. Ansel and I have met with school administrators to talk about policies in school, especially around the pandemic, when we had children with asthma who were having issues with cleaning products in the schools. So, starting even at the school policy level can make a difference. I saw a question in the chat about gas-powered leaf blowers. I've gone to numerous hearings. I'm actually going to one next week, especially now they're virtual, makes it a little easier to attend them, but I presented at tons, and I've worked with a lot of different task forces similar to your program across Westchester County and Connecticut, to just provide that testimony about that. So then working at like the local town municipality level. I presented to the Westchester County Board of Legislators many times on tobacco, a lot of the e-cigarette legislation that's come out, or even just smokeless tobacco. I've gone many, many times again with Dr. Ansel. We partner with the American Lung Association, but meeting with our local Westchester County Board of Legislators. We meet with, there's a lot of work that's been done in the state also through another organization called Clean and Healthy New York. They're an advocacy group, and they were really instrumental in the Child Safe Product Act. I don't know if you've heard of that, but it's similar to like the California proposition, Prop 65, where they talk about just disclosure and labeling. And so we've gone to tons of hearings about that. And we've met, just 2 weeks ago, we met with Governor Hochul's some of her council for environmental programs to really just talk about what we're seeing. I think this group had Senator Harcum here. He's a really great guy. I met with him over the summer to talk about extreme heat and some of the policies that our students dug up at other areas across the country. For example, like we were looking at just what are some scientific evidence that has informed policy about the approach to extreme heat. And so our students did a lot of research, and they met with Senator Harcum to talk about what they found. So we're having these discussions all the time, and we're having them at the state level, we're having them at the school district level, at the county level. So we're really just doing it, and always happy to be a part of the conversation. I will say we do this work together, though. We do it with task force. We do it with our state network. We do it with American Lung Association. So that's really a key part of this, is that when we do this work, it's done as a team with a lot of people who have a lot of, investment in the issue.
Thank you.
Tina had a question that she put in the chat about folks that don't have health insurance. What are the options for them? Like, I know Open Door has a sliding scale for folks, so that you don't have to have health insurance to be there. Yeah.
So I, as you mentioned at the beginning, I wear many hats. So I'm employed by Boston Children's Health physicians. We take insurance. So we see patients who have insurance. The payer type is, about 40% of our patients have a state-based insurance. I then work for Westchester Medical Center, who has a clinic setting for patients who are uninsured, where on Wednesday afternoons, our pediatric pulmonology team sees any patients that are there. So we have models for seeing patients. Just my primary employer is an insurance-based model, whereas any child in the county, especially those who end up in the hospital, who may be either underinsured or uninsured, we have a model for seeing them there too. We work very closely with Open Door. We take a lot of their referrals, and also insurance plans, sometimes insurance lapses. And so we're very fortunate that we actually have 2 social workers who work with our division, and then especially for hospitalized patients. So that's always a priority, is to help get that insurance. Because taking care of children with asthma, if they don't have insurance and they can't get their medications, that's a real critical gap. So that's really a priority for us. But if they don't have insurance initially, no one is turned away. We have a way to see them. It's just a different model than through the Boston Children's Health Physician.
Excellent. Thank you so much. And so everybody, like, we are happy to be like a conduit to get that information to folks if you want to reach out to us. I do want to show, I just don't want us to end without thanking some folks who are really helpful in making this happen. So definitely everyone from the Peekskill Housing Authority, Kim and Ms. Fallon for helping us, Jessica Martinez, one of our former reps, and we're joined at both locations by current tenant reps. Tina, who is helping with doing the tech over at Dunbar. Thank you. Travis, who's our community member and our paid organizer who did a lot of the work. Golden Crust. I don't know why this keeps pausing my screen sharing. For helping us for the delicious food tonight, Dr. Amy Brown and Dr. Ansel as well for being on. Let me try to resume sharing my screen. I don't know why it keeps like going away tonight. But the other thing, so 2 other things that I just want to share. One is our next month's meeting. We are, for December, we're going to do a virtual holiday makers market. So we're inviting all makers, artists, craftspeople to join and share the work that you do, or if you are organizing a craft fair or an event, join us and like publicize so that everybody can buy local and we're not like shipping stuff all over the country and generating waste from our packaging. And we always end on action items. So tonight's action item is regarding a new effort that WAS is joining, which is the Environmental Justice Thriving Communities Technical Assistance Center, which is a lot of words, but it's abbreviated as TICTAC. And what we're doing here is trying to bring technical assistance for organizations, schools, municipal governments that want to apply for grant money. We want to put you in touch and connect you with services to help environmental justice communities like Peekskill, like Portchester, like New Rochelle, Yonkers, connect them with the technical assistance that they need to be competitive in these grants so that we can get this money to our communities and not just like wealthy communities that, one, don't have the environmental problems that we do, but also that have more of the staff. So there's a lot of interesting trainings already taking place through the TICTAC. These are just some of the ones that are coming up. But so our action item for tonight is just asking all of you to help us reach the kind of organizations, municipalities that are rural communities or environmental justice communities and share information about the TICTAC. That's the website, weact.org/TICTAC, TCTAC. So if you know of a worthy org or a municipal government project that really could use the help of experts, please send them that link and encourage them to look there. So with that, I want to thank everyone for for joining tonight, thank our speaker, Dr. Brown, and then thank our hosts tonight for our first hybrid event, because I think it went really well, and we are looking forward to working with all of you in the future. And everyone have a great night. Thank you so much.
Thank you.
Thank you so much for having me.
Our pleasure. Thanks, everyone.
Thank you. Thank you.
All right, we'll be in
Yeah.
touch, and I left the links. Thank you again. I really appreciate the opportunity. Bye-bye.
Thank you all. Thank you so much. From over here at Dunbar, for cleaning up too. We got a lot of cleanup to do. Thank you.
Good night. Thank you,
Thank
Tina.
you.
Bye-bye. All right, let me see. Can't figure this out.